Welcome, everybody. If I haven't met anybody here, my name is Maggie Breslin. I'm been a longtime collaborator with the care unit, and I currently serve as the kind of program director for the Patient Revolution. And I'm guessing you all probably know Ian at this point, right? So through Ian, or do you going to introduce yourself too?
I'm just getting to know me, so yeah, I think I spent enough time talking. Great to have you back again, and take it away, Maggie.
Great. So I'm gonna kind of get through this first part kind of quickly, just so that we have more time, I think, to reflect on the exercises and sort of work together collaboratively. I think this is actually a really interesting workshop to have as the kind of end, the kind of capstone to the event, because it is really about taking a lot of the discussions and over the last 2 days, and then thinking about what do we do with them and how do we turn them into something that maybe can begin to affect some of the conversations that we've been talking about. Design as both a method that has been a part of the care unit for since the very beginning, or certainly since my collaborations started with the care unit in 2005. The diabetes issues cards were actually the first project that I worked on with the care unit and with Victor and the team. And I think that the sort of process, while we've learned an enormous amount in the last 17 or so years, the process itself, the sort of steps that we use to develop our communication tools or conversation tools, hasn't really fundamentally changed. And it really sort of follows these 4 steps. The first one is observation. So we always try and ground our understanding of the problem or the issue or the situation that we're trying to address or bring a tool to by observing in the real world conversations that clinicians and patients may be having about this particular topic, so that all of that kind of understanding can be used to inform what we actually put together. The second stage is the evidence synthesis. So once we have a sense of what things might be important or interesting for patients and clinicians to talk about, looking at the evidence to understand what do we have to say about that, what could we offer potentially into the conversation. The third step is prototyping. So this activity is about trying to get away from the sense of kind of expertise, and instead we make early prototypes, give the information some sort of shape and form, and then ask real clinicians and real patients who are really having these conversations to use those tools in order to understand, is it successful in helping people communicate ideas to each other, to talk to each other in a different way, ask different questions, make different plans. And based on what we can see in those interactions, we then refine the tool, hopefully getting closer and closer to something that is more likely than not to help clinicians and patients have a conversation that's going to be meaningful and relevant and productive for them. And we do all of this work when possible in the real world, because that's the best way that's the best kind of information that helps you really shape something that you know is going to function the way that you want it to in the sort of messy, complex world of healthcare. So this is just a little bit of a glimpse of kind of observation. Observation can take lots of different forms, can be videotaping encounters, which is a big thing. I think it was often talked about earlier as well. On the left-hand side there, you see a sketch from one of my sketchbooks when we were doing some observations in the hospital. So, you know, you're looking at all kinds of things. Who are the people involved in it? Where are they sitting? How are they facing? What kind of body language and things maybe are happening in that space? as well as the content of the conversation and which things are kind of jumping out to you that might be relevant to the issue that you're trying to address. Then evidence synthesis. So this is some examples from the, or I guess, no, is this prototyping, Ian? Okay, anyway. So these are early prototypes for what many of you probably know now as the ICANN tool. And so they were ways of taking the topics and issues that felt relevant to help patients and clinicians have a conversation about. These were things that were tried. One of my favorites about this was the, and I think is so amazing and powerful about the work that the team did on the ICANN tool, was the genius kind of decision to allow people to check that something was a satisfaction and a burden. And I think that was really kind of revelatory in terms of acknowledging that there can be things in your life that are helping and hurting at the same time. I think the next screen gives you another example of prototyping and what you kind of learn from prototyping. So this actually was the very first prototype for what became the diabetes issues cards. I called them baseball cards because they were very data heavy. They're very, reliant upon kind of like research evidence in terms of numbers. And people liked them because people like to get stuff, but they couldn't use them. They weren't able to help start or engage people and patients in different ways. And so that sort of revelation. And then the second version after this was narratives, turning those into narratives. That still wasn't effective or working. And then it was after that we actually took the version of this that was narratives and cut it up and rearranged it according to the issues rather than according to the medications. And that was what kind of cracked open that particular project and a lot of this communication tool work, conversation tool work over time. And with that, a little bit of a quick overview of what the process looks like, I'll hand it over to Ian.
Thank you, Maggie. That was awesome. I've known Maggie a good long while. We went to graduate school together and then...
Oh, louder.
Louder is what that's saying. Okay, I'm going to lean into this microphone again. So I had the pleasure of going through graduate school with Maggie, and we've known each other for, I don't know, 18 years now, something like that. So fantastic to work with you, Maggie. So what we're thinking about here is how do we go about designing shared decision making? So, or how do we design to facilitate shared decision making, which has been a big focus of the care unit work. Yeah, take that off. And so to think about that, you have to have some sort of sense of what you're designing for or what shared decision making is. So our working account of shared decision making here is that shared decision making, very simply, is a conversation in which patients and clinicians work together to figure out what to do in response to a human problem, day in, day out, business and medicine. And the purpose of that is to co-create care that makes intellectual, so medically sound, practical, feasible, and emotional sense for the person in their situation. So how do we design to support that? So I think one of the things to pay attention to, and this has very much been a focus of our work and Maggie's work, is this idea that what you're designing when you're designing shared decision-making interventions isn't a set of cards or a computer interface or a visual presentation of risk and the like. What you're designing is a conversation, or you're designing for a conversation. We're not trying to script the conversation, but because shared decision-making happens in this conversation, that's really a significant part of what we're trying to work together to design. But there's other elements here as well. So a good conversation is important. Designing to support the working together of people is important. designing to support the figuring out what to do, also an important component. And obviously designing such that whatever it is that we're trying to develop actually helps patients and clinicians attend to whatever problem is at hand. And so a little shortly, we're going to break you into breakout groups, and we're going to quickly run through a design exercise. And the focus of that exercise is developing some sort of shared decision-making intervention to assist patients and their doctors discuss issues of alcohol use within clinical encounters. So tricky conversations, lots going on, lots of things leading up to it, lots of things that could come out of it. No clear-cut answers necessarily of how to handle it. So we're going to try and think about, well, how can we actually help in this context? And some practical orientation for that is that what we found is that the most important thing in designing a conversation aid, and I should say that conversation aids aren't necessarily shared decision, the full gamut of shared decision-making interventions, but we do develop a fair number of them. But the most important step is trying to figure out what problem you're trying to help with. So what's difficult in conversation, what makes it hard to figure out what to do, what makes it challenging to actually put all the pieces together in a plan that actually responds to the patient's problem. And Nike very nicely led us through an example which completely independently I'd put in my slides as well. So this is very timely. So several years ago, we were asked to think about developing, it was cast as a decision aid to help in shared decision making for kids presenting at the emergency department with acute otitis media or earache, ear pain. And the project was initially kicked off in some ways from a de-implementation angle, which being that antibiotics are overprescribed in this situation, and because the vast majority of these kids have a viral, not a bacterial infection. So that was the initial framing of the problem. Too many people are having antibiotics. What can we? And the premise being, well, if we were able to put together some nice presentation, we could convince people not to do that. But as we delved deeper into it, we came to the sense that, well, parents and kids aren't turning up at the ED because they don't understand the limited effects of antibiotics. That's not why they were coming to the ED. And I should mention a little bit of background. The reason this was focused in the emergency department was that often after hours, when you can't see your primary care physician, it's late at night, you bring your kid to the ED. But folks who work in the ED aren't necessarily pediatricians or particularly expert at this particular issue. So that was the point of locus. So if the problem isn't that people don't understand, what do we do about that? So if it was a lack of understanding, we could have stopped the tool here, which is a risk presentation of how likely it is that if you take an antibiotic, your kid will feel better. And what this is saying that if you look at 100 people, 100 kids like you, 4 of those kids will feel better as a result of taking an antibiotic now. Fairly small number. But as I said, it wasn't a lack of understanding that's the issue necessarily, although understanding more might help move forward. And so this is, again, one of my favorite quips. And coming from the research angle, where problems look like knowledge gaps, from the design perspective, a knowledge gap is not a problem. More knowledge, more clearly understood knowledge, whatever might be a potential solution, but it in itself isn't a problem. And so I loved Zoe's comment about the idea of knowledge mobilization. This is very much along those lines, is if we have this knowledge, the issue isn't so much to translate it, it's actually to mobilize it in such a way that it actually helps people make good decisions. So where we came to is that, well, what is a problem? Is your kid screaming, it's 2 a.m, you've been up for hours and hours and hours, you're worried, you don't know what to do, your GP is closed. Now that's a problem. And so that's what we settled on, that we want to try and help people have the sorts of conversations where actually that very real problem could be dealt with. And so what we did I only showed you one very small part of the conversation aid around that, is that we recast the problem not as ear inflammation or acute otitis media, but we cast it as ear pain. And the question is, what do we do to help your kid in this situation and you get some rest, move on with your life? And so then the issue wasn't so much antibiotics, no antibiotics, is what can we do to help? And so then it turned to a setup, well, whatever we do, we're going to address this pain. So we're going to want to make sure that you're taking or you have available the sorts of over-the-counter medications that are often indicated. Then if we want to turn to antibiotics, we can look at it and say, well, chances of it helping are fairly low. You're much more likely to encounter side effects, diarrhea and the like, than you are to actually gain benefit. But at the same time, we want to do something. And so there's some options. As a clinician, I could prescribe antibiotics now. You could go fill it. Or I could give you a script and you can take it home with you. And if you feel like things aren't improving, or you really want to move forward and do something, you go ahead and take it to the pharmacy, or we can wait and see how this plays out, and the chances are go from there. So it's setting it up in terms of practical action in order to manage the situation that you're in. And so our shared decision-making interventions, the goal is to help tend to problems, very much linking back to the purposeful shared decision-making work. And so if we look at the types of tools that we develop, they vary somewhat. So this is an intervention to help discuss the risks of heart attack and the possibility of treating it with statin therapy for primary prevention. You'll notice this is talking about effects to link it back. So this sort of tool is quite helpful if the issue is the effect. So you have a heart attack that has adverse effects, you have a medication that has beneficial effects. But then there's other situations, and Maggie can chime in here too if I'm misrepresenting your work. But so this is work that was done many years ago for the Nicotine Dependence Center here at Mayo around the issue of, well, how do we manage smoking perioperatively? So you're going into surgery, there's some benefits to stopping smoking, going through into surgery and recovery. What do we want to do? And so we can think about, well, there's actually good things about continuing to smoke. There's some positive, it calms my nerves, I'm going into surgery, a lot of anxiety, I just don't want to take on this pressure. Or it's an opportunity to quit for a bit. Let's see if I can do this for now, get the benefits, and then I'll reassess, or could move into a possibility of quitting for good. So what we're focusing here on is a situation. You're going into surgery. How do we make this situation work best, going in and going out? There's a little more content there. The ICANN conversation aid, again, focused on situations, not on effects. So the goal of this tool is to actually, identify, what situation should we be dealing with today, where things are ambiguous and care for multiple chronic conditions. So this is focus, like I say, is, how would we even discover what sort of situation is a problem to set us up to address it? No discussion of effects here. And then Maggie, I'm going to turn this over to you to talk about a little.
Yeah, this is a tool we've been working on with a team at Yale. We call it QB Safe. And the idea was to develop an intervention that could help people living with diabetes and their clinicians have a discussion about diabetes treatment or ways to manage their diabetes that didn't singularly kind of focus on A1C and numbers. And so through a lot of observations and discussions, we developed this kind of set of cards. The QB Safe stands for quality of life, burden of treatment, safety. I'm forgetting something. So safety was around, I think, preventing hypoglycemia. And so we developed these kind of tools, and the idea is that patients can select 3 or 4 of these cards, and before the visit, before the clinician comes in, and then they can share them with the clinician, and they help kind of structure and support the conversation. And as we did the research on it, I think some of the things that were really interesting is it was actually the diabetes nurse educators who recommended to us to have some cards that were positive, allowing people to talk about positive impacts on their lives from their diabetes or feelings of pride that they've had. And so that was, a really kind of powerful addition that came through that prototyping and engagement phase. We also found early on that it revealed a lot of people choosing the diabetes is impacting my sex life card, which again, most of the clinicians we were working with said that that was not something that regularly came up. And so an offshoot part of the team actually began looking at what the research said about diabetes and sexual function and what sort of things might be able to offer. So I think it sort of suggests not only is it these kind of tools can be useful for helping clinicians and patients have productive conversations, but they also can spring off additional research or other kind of projects, and engaging different types of clinicians can kind of open you up to different insights and work. So.
Wonderful, thank you. And again, different type of conversation aid. In terms of Zoe's metaphor of mobilizing knowledge, this is about, how do we mobilize the potential of the conversation so that we're actually addressing things that matter to people. And then finally, this is an example of work in progress. It's a very unusual sort of conversation aid. It's to help people and their families and their care teams think through the decision of whether or not to proceed with hand transplant. It comes out of work that we were doing with the DoD, looking at face and hand transplant and the way that decisions are made in that. And I think the reason I brought it up here is that you may recognize that each of these 4 circles correspond to the 4 modes of purposeful shared decision making. And this is a great example where just talking about the pros and cons of getting a new hand or an immunosuppression doesn't do justice to the sorts of issues that are at play. There's many people are involved. It's not just that you walk into the clinic one day and walk out with a new hand. You have all these people who have to care for you, take on responsibilities, may have different desires for you, may be worried of what you're putting yourself through. You have a very large care team, all of which have to be on board with why you want to do this, feeling that your motivations are well-founded and the like. So there's that dealing with different people's positions in order to come to a decision. There's the situation itself. So what is it about living without hands that's made your life hard, and that's a problem we want to deal with. But in terms of the problem solving, there's just so much to organize. So for the Mayo Clinic practice, you have to move to Rochester for 6 months for rehabilitation. If you have a family, you're going to need a caregiver with you. So there might be things like coordinating child support or who's going to look after the pets while you're gone. A lot of financial things to put in place. And the like. So there's a lot of practical situation type things, and even more so in the context of face perhaps than hand. It's a deeply existential decision that the situation you're in often can go to the core of who a person is. As I say, particularly if you are missing a face and you're considering a face transplant, that can really go to issues of self. So that requires exploration. So we're beginning to build out tools that allow us to think about addressing each of these different things that need to be put in place in order to come to a well thought through decision. And so with that in mind, I will pause very briefly to see if anybody has any questions or comments, things that we could clarify before we go into the exercise of thinking about how to design something to support conversations around alcohol. Any questions? Things that we could help clarify around what we've been talking about, design and design for shared decision making? That's fine. It doesn't have to be questions. Maybe there will be after the exercise. So what we're going to do now is we're going to move into a phase where, again, we'll put you in breakout groups. And this is sort of the exercise we're going to go through. And we might move through it a little more quickly in the interest of time, but this is the broad stretch of things. So first job is to identify some sort of situation in which it's hard to talk about alcohol use, either with your clinician or with your patient. So when does alcohol use come up as a problem and it's hard to talk through? And the handout that's associated with this, which Casey pointed to you to earlier, has alcohol in the name, as I recall, is a set of, I think, 3 situations that we think are difficult, but there are many, many more. So you're free to choose any of those situations that are on the sheet or completely make up a new one from scratch. And it's funny that conversations about alcohol up at 2 a.m. Yeah. Maybe we should have put alcohol therapy on the card, on the decision aid. And then, because, as I say, our focus is on designing to support these conversations, in order to create something, we need to understand what those conversations are, what they look like, why they're hard, what's covered in them, what are the opportunities for assisting and supporting it. So we're going to ask you to split into a clinician, patient, potentially a family member could well be in the room, and role play a conversation. And the people who aren't participating, observing that conversation, trying to get a sense of what's going on and what's hard about it, as I say. And at that point, we'll come back as a group and we'll talk about what's happened so far. And after that, we'll launch on to the next phase. Does that make sense for everybody? Any questions?
We decided to discuss about the second patient, the 18-year-old daughter, in regards of alcohol conversations. So we came out with the conclusion that it is always recommended to have a conversation with the adolescent alone, so we can build rapport with him or her, so this patient can trust the doctor and not being like constrained by her mother or her father to hide some information that could be sensitive for her. Sure. So this is like the first step that we decided it will be ideal to have an encounter along with the adolescent, and then to be non-judgmental and try to explore the patient's beliefs and what is she doing or what is she considering as a bad influence, like when she hang out with her friends. And probably she will be in this pre-contemplation stage of the change model. So we should be start on that and trying to identify why she doesn't think this is a problem. And then we can go on like to the contemplation stage and so forth.
That's great.
So this is what we decided. It will be good.
We're going to work there. So I'm going to ask another group to talk about what their experience was. I think I'm particularly interested also in what was hard. So where was the conversation challenging or difficult, or what made it hard? Do others in the room or online want to tell us a little bit about what they did together?
Hard, Andrea?
Hi. Oh, I think Maggie wants to talk.
Oh, Maggie.
Please speak up.
No. I mean, I did join a group, I guess. I could help out by sharing for Nike and Michael and Anne. But y'all jump in and say if there was kind of something else. So they actually picked the first issue in part because there was a little bit of a question, I think, about, the idea of the clinician having information about the patient that wasn't disclosed by the patient, but was disclosed by the patient's kind of family member. And so we thought that was, or I thought, I don't know if they did, I said, it creates an interesting kind of challenge for a conversation tool in terms of how to, can you design something that would engage a patient in a conversation that would allow them to bring that information to you in a way that then you could use it and help sort of shape the plan that happened, from that. And so Nike and Michael kind of played it out, and it was really, it was super challenging, I think, to when a patient was presenting with issues around headaches and sleep issues, even though Anne pointed out that, sleep and alcohol use, there's, really kind of strong kind of correlation there. But, potentially trying to use that as a way into the conversation, and maybe does that create some space for the patient to reveal about their alcohol use in relationship to sleep. And so that was, it was fascinating to kind of play that out a little bit. And then Anne was mentioning that at the VA, they have a yearly alcohol use screening kind of right at the end before we were kind of coming back. And I don't want to speak for her, but she can pipe up, but that she found that was really useful to just have as like a regular thing that happens within their system, because it then means that, she was saying it's time for you to do the screening again. And so there was a way to bring that topic into the conversation without, that was kind of dictated by something outside the room. And I'm guessing, Anne, you please correct me if that's not true.
A lot of the VA patients may just come in yearly. And so it's just there's all sorts of clinical reminders that get done, and actually nursing staff does a lot of those. But if there's anything that comes up positive on that, then I take the ball and run with that. And sometimes I actually do the alcohol use screening. So it's just become a part of many visits. So even if they're coming in more frequently, sometimes I just touch base on alcohol and tobacco use because they are so prevalent in the VA population. I've just kind of made that a part of my usual review of systems, really.
That's great. It sounds like a great conversation, and I'm already seeing the seeds of a couple of possible interventions that could come out of that. So the shifting of the conversation from alcohol to sleep, for example, is a point of the issue, or as you say, building these discussions into the institutional process. So it's maybe that moves it away from I as a clinician probing your business to this is part of what we do when we care for you. Different framing approaches. Jen, Barton, would you like to? What happened?
Wow, I just got really thinking. So I think we picked the second scenario, and I was the clinician and Karen was a patient, and we had the mom, Elizabeth. And, I think these are really difficult things we did. I did ask the mom to leave the room, I think so. The same thing. And really for me, it was about rapport building and building trust and, just getting Karen to talk about school, to talk about life, to talk about, whether or not she thought this was a problem in a way. So it was really, we were just getting into it, but it was, it's a challenge. It's not easy. And it makes one feel very uncomfortable, I would say, as a clinician. But I think that, trying to normalize this and having time to reflect, for the patient to kind of reflect. And it's about trust and it's about building a relationship, I think. And
I think you're absolutely right. And so that raises the question, how much of this should be done through a computer interface? Maybe that isn't the right way to be promoting shared decision-making in these sorts of contexts. Maybe we should be thinking about a different intervention and the like. And you're right, it's challenging for clinicians. I imagine it's very challenging for patients as well. So the goal of trying to help these conversations, I think, is worthy. So what I didn't hear anybody talking about in this conversation is the effects of alcohol use, although perhaps effects on sleep. Did anybody go into the harms of alcohol use?
I think I tried to explore this with Karen, was like, is it impacting your schoolwork? And then she also, we were just talking about other things. She talked about stopping doing sports as frequently, but she didn't think it was, and again, I don't want to speak for you, Karen, I can't remember everything, but I did start to talk about how it may be impacting her life.
I was maybe a little teenager-ish in the of actually not, I think how you bring up harm recognition where there truly is none in the initial conversation is actually a challenge for some of this. And while we recognize harm, then sometimes that's not the case when someone else presents, or that association isn't made, and it's how you bridge that.
This is Mark. We talked a little bit about harms, and I think you can sort of back into these things, and alcohol and tobacco get sort of lumped into one category, but they're basically medication. So if somebody came in and said, I'm having a gnawing stomachache and vomited some blood, and I take 12 ibuprofen a day for the last month, we'd say, it might be from that ibuprofen. And when someone comes in with trouble sleeping and a headache, I think most of us are going to figure out we're going to be exploring alcohol and tobacco in there somewhere. But I don't think it is about delivery and trying to make that help the patient understand that there may be a connection without accusing them. Get at the earlier issue about how do you have that information ahead of time, and we talked about that. That's a real challenge. Family member buttonholes me before the appointment. Don't tell dad I told you, but he's been drinking more. And it's a similar situation as saying, well, I'm not going to lie. And what I'd really like is for you to come into the room with us. Maybe you'd like to talk to your dad and see if it's okay if you come in with him. Things like that. I think there are strategies, but I think that's the art of things that we all try to muddle through. And I think we probably all do it imperfectly. And I also think that's okay.
Champion clinician, so but I like what you said about being the encounter like a safe place. So you know, those kind of situations, sometimes when we were talking about a mode 2, when there's different positions, you know, you have the positions there, but it's hard to discuss them when it's your partner or it's someone you love, and being able to talk that. So I think having the consultation as a safe place to be addressing them, letting the clinician guide those, how to work through those positions. I really like that idea of being a safe place to carry out that.
We also had a discussion that went a little bit beyond just talking about like the sleep and like you mentioned. Are those the main concerns that you have, or are there other, like we established that the alcoholism may be a consideration, and then after that you asked about some other concerns and like how it makes your other family members feel too, and just outside of kind of those more biological feelings. I thought that was an interesting turning point in the conversation that we had. Like, well, you don't want to make your wife feel bad, so kind of did like a hybrid model too, where she came in the room. But
very cool. So what I'm hearing is a lot of repositioning, moving sort of the grounds for the conversation around. So I love what you suggested, Mark, of turning the idea of alcohol into a treatment or a medicine, and saying, and so taking the issue of alcohol use away from the person. It's a characteristic of the alcohol. It's not a characteristic of me as a person. And maybe that opens up opportunities to talk about things that wouldn't be possible if it was, I'm concerned about your alcohol use versus I see you're having all these troubles and look, what are you doing? This is doing, well, it's not, it doesn't seem to be working, or that's having these associated harms and like that. Similarly, shifting the issue to sleep, for example, or shifting the authority to the institution rather than me as a clinician. So it's not me telling you that you need to stop drinking. It's part of the system, for better or worse. These are all different opportunities to sort of shift the ground on which the conversation is playing, and they all open up different potential ways of moving things forward. Now, how many of these are translatable directly into the sorts of conversation aids that I shared earlier? Open question. I think rather than move into trying to sketch out what those interventions might be, which would be the next thing we would do in design, is, okay, we have a sense of why this is hard. We've come up with some ideas. What would these look like practically? Let's take them into clinic, ask folks to use them in their conversations, observe those conversations, see where they're helping, see where they're failing miserably, or see where they're just sort of not doing anything at all, and then go through a process of iterating from there.